Poster number 17, emergency visits and readmissions in an enhanced recovery pathway, opportunity for quality improvement, being presented by Tanya Castelino.
I'd like to thank you for the opportunity to present our work today.
It's the, oh no, it's the green thing.
It has a light on it too, if you'd like.
Great, thanks. I have nothing to disclose. So enhanced recovery pathways are multimodal, multidisciplinary, and standardized perioperative care pathways that are designed to reduce surgical stress. They're comprised of many different interventions in the pre, intra, and postoperative periods in order to fast-track or enhance a patient's recovery after surgery. They have been associated with decreased length of stay as well as decreased morbidity after surgery. So the questions that we sought to answer with this study were, does shorter hospital length of stay lead to more emergency visits and readmissions within an enhanced recovery pathway after colorectal resection? And are there any identifiable risk factors for having increased emergency visits or readmissions? So in terms of methodology, we did a retrospective review of a prospectively maintained database, and we included adult consecutive patients undergoing elective colorectal resection at the Montreal General Hospital from September 2012 to May 2014. And all of the patients were treated within our enhanced recovery pathway, which has a target discharge of 3 days. Our patients, we had 227 of them, and they were typical of a busy colorectal practice, with approximately half male, the vast majority undergoing laparoscopic surgery. That was 73% of them. 60% of our patients underwent surgery for malignancy, 15% for IBD, and 27% of patients had a new stoma formation. Our median length of stay was 4 days, and I'd like to draw your attention to the emergency visits and readmissions. So we had 20% of our patients who returned to the emergency room and 14% of patients who were readmitted within 30 days of surgery. And of those patients coming to the emerge, 65% of them did require readmission, and I'll get to the reasons for readmission in the next slide. We analyzed our patients in 2 separate groups, those that had a length of stay within the 3-day target of our pathway, and those that had a longer length of stay. And we found no significant difference between the groups in terms of risk for emergency visit or readmission, and in fact found a trend towards a higher emergency visit and readmission in the group that had longer lengths of stay. So these are the reasons for emergency visit that we've split up into 2 groups, those that resulted in readmission and those that did not result in readmission. So you can see that the reasons for readmission were for serious medical problems that did require a hospital stay. And we chose to focus our attention on those visits that were not resulting in readmission, and the patients presented for complications with their wounds, respiratory symptoms, and issues with stoma and urinary retention. We found that there were no risk factors for emergency visits, and the only independent predictor of readmission was new stoma formation. So we feel that emergency visits for minor complaints need to be targeted because that's the place where we can better improve delivery of patient care. And we feel that the preoperative education that they receive should be continued throughout their admission and reinforced upon discharge, preferably with written instructions as to what complications they can expect to see. And we should also have these patients have surgical clinics that are easily accessible to them so that these minor complaints can be dealt with in the clinic rather than necessitating an emergency visit. So in conclusion, we found that the shorter length of stay is not associated with increased risks of emergency visits and readmissions, and that the only predictor of readmission was a new stoma formation. Thank you.
Thank you very much. You guys do great work up there with the ERS pathways.
Can you comment on your stoma education rate before what kind of education of the patients is done before they go home? If stomas are your problem, maybe you can target teaching them better how to care for it or what to expect in advance?
Yes, thank you for the question. So the patients are seen in preoperative consultation with a stoma nurse, where she marks them for appropriate stoma placement, and she starts to introduce them to all of the equipment that they'll need and the materials that they'll need to maintain their stoma. She also visits them while they're in the hospital prior to discharge to explain to them what types of complications that they can expect. Their resources are quite spread out, so there's only one stoma nurse for that hospital, for the Montreal General Hospital. So she does make an effort to see every single patient, but probably we don't spend enough time with them, and we also probably don't give them written instructions. So I think we can improve upon that in that respect.
Thank you.
Thanks.